Welcome to today's CEU course. My name is Justine Sherman. I am a speech pathologist for the last 28 years, and I am the proud owner of Justine Sherman and Associates, and we are a private practice with 3 clinics in Southern California. And we have remote therapists all over the country serving clients throughout California. And we've had JSA for 19 years in January, and I have the most amazing team. And we do monthly CEUs. So I started putting this together for my team, and I thought this would be great to share with all of the SLPs out there. Okay. Okay, so we're starting with learning objectives. So I want to welcome everyone here. I am so glad you're here because we're diving into a topic that is foundational, but often undertaught, which I saw in a lot of your comments that you really didn't get this information in grad school, and that is the oral peripheral examination. So my goal today is to equip you with a systematic, confident and clinically meaningful way to complete OPEs and to help you understand the why behind everything you're looking at. So when you leave here, your assessments will be more accurate, your treatment planning will be tighter, and your referrals more precise. That is our goal. So why a thorough OPE matters. Too often, clinicians rush through the oral exams or they only assess what moves during speech tasks. But the OPE is not just a quick look, it is our chance to understand the entire oral facial complex. And we're looking at structure and tone and symmetry, mobility, airway, sensory components, compensations that we're using, and the functional impact. So today I'm going to be drawing from my 27 years as an SLP. I'm also a certified orofacial myologist. And I can tell you that a thorough OPE is one of the most powerful clinical reasoning tools we have. So when it's done well, it helps us identify structural and functional contributors to speech and feeding, resonance and airway issues. It helps us determine possible causations behind errors or behaviors we're observing. It allows us to build truly individualized treatment plans, and it helps us know when and why a referral is needed and who that referral should be. So the teaching tip I have is anytime therapy that has to do with speech or feeding or resonance isn't progressing the way you expect, the first place I want you to go back to is your OPE. Okay. So before we even talk about anatomy, we need to talk about safety. Every oral peripheral exam involves mucous membranes, so that means standard precautions always apply, regardless of the diagnoses. So that includes proper hand hygiene, gloves, and cleaning your tools between clients. So just a clinical tip, I always normalize gloves by saying something like, I wear gloves so I can get a really good look and keep everyone healthy. That keeps it from feeling medical or alarming, especially when we're working with children. And we have tools of the trade. So these tools may seem basic, but they really do matter because a poor light source can lead to poor clinical decisions. So a flashlight or a headlamp lets you see symmetry and color, maybe swelling, movement. A tongue depressor is for stabilization, not force. And a mirror is incredibly helpful for checking nasal airflow. So if you can't see it clearly, don't guess, adjust your setup and your tools. So let's start with postural tone. Posture is the foundation of the entire orofacial mechanism. And I start assessing it the moment the client walks into the lobby, not when they sit in my chair. So I'm observing posture globally before I ever isolate it into the mouth. And how the body organizes itself in space directly impacts how the orofacial system functions. So, how do we assess posture during the OPE? First, we observe at rest, not on command. So, I watch the client walking into the room, sitting in the chair, waiting between tasks, and this gives me far more information than if I ask them to sit up straight. And what I'm observing is upright versus slouched posture. And I'm asking, is the head stacked over the shoulders or is it forward? Are the shoulders rounded or internally rotated? Is the trunk supported or is it collapsed? And you can look at all those in these pictures here. Now, upright posture supports efficient breath support, stable jaw positioning, optimal oral rest posture, and refined motor control for speech and feeding. It is all related. Slouch posture, so if we're kind of looking at this guy here, results in reduced respiratory support, jaw instability, low and forward tongue posture, and an increased compensatory movement during speech and feeding. So we're going to talk about stability, mobility, dissociation, and grading, and the clinical meaning behind those. So let's start with stability. Stability is the ability to maintain a controlled, supported position. In the OPE, I'm asking, can the trunk stay stable without kind of constant shifting? Does the jaw remain steady during speech and movement tasks, or am I seeing shifting there? Because the jaw acts as a mobile stabilizer for the tongue and the lips. So if postural stability is weak, then jaw often works to overworks and it will have to compensate for the postural instability. And that leads to sliding, biting, or excessive jaw movement. Clinically, this may show up as reduced speech clarity, jaw movement during tongue-driven tasks, or fatigue during feeding or sustained phonation. Now we'll move on to mobility. So mobility is the ability to move efficiently through range without restriction. I'm observing whether the posture looks rigid, it looks collapsed, whether the client can adjust the posture without losing control. And limited mobility often leads to excess tension in the neck and the shoulders, which restricts the jaw and the tongue movement. So clinically, this can look like reduced oral range of motion, even when the structures are anatomically normal. Now we'll move on to dissociation. So dissociation is the ability to move one part of your body independently from another, and it is critical. I'm asking, can the jaw move without the head moving? Can the tongue move without the jaw following? And can the lips move without the excessive jaw or mentalis activation? And this is your mentalis and your masseter. So we have speech and feeding, which requires refined dissociated movements. So poor dissociation forces compensatory patterns that reduce precision. And clinically, this may look like head movement during tongue tasks. So moving side to side, but I need to move my head. Jaw lifting during lip tasks or whole body movement during oral motor activities. And then lastly, we're going to look at grading. And grading is control of the speed, force, and the range of movement. So I'm observing whether the movements can be slow and precise, intentionally stopped and started, and smoothly controlled rather than kind of abruptly stopped. Because speech requires fine grading of airflow, of voicing, and of the movement of the articulators. Feeding requires graded jaw and tongue control for different textures. So if our grading is off, we could have overshooting or undershooting or sort of an all or nothing movement. And these are our red flags, which will reflect poor postural tone or motor planning challenges. So how postural tone impacts function. So remember, we're always looking at how the things that we're seeing within our OPE impact function. So poor postural tone can explain persistent articulation errors, reduced intelligibility with fatigue, difficulty sustaining phonation. Can you imagine being hunched over, rounded shoulders, how difficult it is to sustain phonation in that posture? It could have poor bolus control or excessive jaw and head movements during speech, especially when progress is limited despite appropriate intervention. So forward head posture, that's this guy right here, a key clinical clue. So when I see forward head posture, I immediately think about airway and breathing patterns. Because a forward head posture often correlates with mouth breathing, low tongue rest posture, narrowed oral and pharyngeal space, and increased effort for breathing and speech. It can be both a compensation for airway issues and a contributor to ongoing dysfunction. So, looking at all this, who are we referring to if we see problems? So, when postural tone is clearly impacting orofacial structure and function, we may need to send to an OT to address core stability and sensory motor integration. We may send to a PT to address alignment and movement efficiency, or an ENT or medical referral may be warranted if airway concerns are suspected. So the bottom line for SLPs is posture is not peripheral in the oral peripheral exam. It is foundational. If the body can't support stability and mobility, dissociation, and grading, the orofacial system will compensate. And identifying these patterns early helps explain therapy challenges and guides targeted collaborative referrals that improve outcomes. So now we're going to look at symmetry. So once I've observed posture, I move to facial symmetry, both at rest and during movement, because symmetry gives me critical information about neuromuscular control, structural integrity, and compensatory patterns. So facial symmetry is not cosmetic. It really reflects how cranial nerves, musculature, and the airway are functioning together. So, how do we assess facial symmetry during the OPE? As always, I begin with the face completely at rest. I observe the eyes, nose, lips, and lower face and jaw, looking at overall balance, tone, and alignment. So, resting symmetry shows me baseline tone and structural organization without the influence or the effort of compensation. So next, I assess symmetry during intentional and functional movement. I will ask the client to smile, to pucker, to retract the lips, and to alternate from puckering and retraction back and forth, and perform tongue tasks while keeping the face completely relaxed. What I'm watching for is whether one side moves less, if one side lags, if there's tremors, or if one side overactivates, and whether asymmetry increases with effort. So what we should be analyzing is one, rest versus movement matters. This distinction is critical because if asymmetry is present at rest, but improves with movement, this often points to a structural difference or habitual posture or resting patterns. Motor control is likely intact, even if the alignment or the tone is altered. If asymmetry appears or worsens with movement, I'm more concerned about neuromuscular weakness, cranial nerve involvement, especially cranial nerve number 7, or reduced motor control under demand. So now we're going to look at that stability, mobility, dissociation, and grading in facial symmetry. So stability, I assess whether the face maintains a stable resting posture. I look for drooping, jaw deviation without movement. I look for poor stability, which often leads to overuse of the stronger side during speech and feeding. When looking at mobility, I observe whether both sides are moving through a full smooth range. So reduced excursion or restricted movement may indicate weakness, tethered oral tissues, or post-surgical changes. And then with dissociation, I'm looking for independent movement of facial structures. So lip movement without the jaw involvement, facial movement without head and neck assistance, and tongue movement without kind of facial pulling. Those are all key. So poor dissociation may show up as head turning, jaw lifting to assist the lip closure, or excessive mentalis activation. And then again with grading, Grading is control of force, speed, and range. So I'm observing whether the client can produce small versus large movements. Can they hold their posture and release smoothly? Is their speech able to have graded, finely graded facial movements? Because poor grading often affects precision and intelligibility in speech. So let's discuss that functional impact of facial asymmetry. Facial asymmetry can affect bilabial and labiodental sound productions, overall intelligibility, saliva control, feeding efficiency, and facial expressiveness during social communication. And with our clinical interpretation, remember, context is everything. Asymmetry is not inherently pathological. It's the pattern that matters. So contributors may include neurological conditions, structural or surgical history, dental or occlusal asymmetries, chronic airway obstruction, or longstanding habitual patterns. This is why detailed observation and descriptions are essential. So, documentation should be strong. Rather than documenting facial asymmetry noted, I will describe the pattern and conditions under which it appears. So, I might write mild right-sided lip weakness observed during retraction tasks, increasing with sustained movement, symmetry improved at rest. This level of specificity supports a diagnosis and treatment planning and referrals. So, the referrals we may be considering when asymmetry impacts function or worsens with movement, we may include a neurologist, ENT, dentistry, orthodontics, OT, and PT, depending on the suspected contributor. The bottom line for SLPs is facial symmetry reveals how well the system is organized and controlled. By comparing rest to movement and analyzing stability, mobility, dissociation, and grading, the SLPs can differentiate structural variations, compensation, and true neuromotor dysfunction. And all of that will lead to more precise, effective intervention. So here's questions for you. And again, remember, I can't see you, so just turn your microphone on and yell it out. We have Napoleon Dynamite here. Based on this posture alone, what might you predict about jaw stability? Anyone can yell it out. What do you think with rounded shoulders, forward head posture?
Low?
Low. We have low tone, right? And low jaw stability. So what might this posture do to breath support for his speech?
Decrease his breath support?
Absolutely. And how could this posture affect his oral rest posture?
It looks like he has open lip posture.
Yep. Open lip. What do you think about his jaw and his tongue? What's happening there?
Low forward tongue.
Low forward tongue, right? He's all forward. The jaw is forward, mouth is open, tongue is probably low and forward. So before, when we're looking at rest, when he walks in, before we've done anything in our OPE, we can already go, well, he probably has poor breath support, rounded shoulders, which is causing the head to move forward, which causes the tongue to move forward, open mouth, so he's probably a mouth breather, and we can start making our judgments there. Great. So now let's look at this young lady here. What do you notice about her face at rest? Say on this one.
Right-sided
Asymmetrical.
drooping.
Asymmetrical, right? So what looks the same on both sides?
Her left side is the same on both sides.
Left side. Oh, on both sides. Sorry. Yes. So, but on here, what if we were looking sort of at symmetry? Does anything look the same?
Let's say her nose kind of looks symmetrical.
A little bit. Yeah, the right
Mhm.
side's a little bit lower, right? But look at the lips. Those actually look pretty symmetrical, don't they? But where does your eye go first when you look at her face here?
Her eyebrow and her forehead.
Yeah. And so kind of the whole right side is just, we're looking at this cheek and lower, and you're starting to see it at the eyebrow level. Good. Awesome. Okay. So now we're going to move on to airway and nasal passages. So this is one of the most commonly overlooked parts of the oral peripheral exam, and it's one of the most clinically significant. And it's something as an orofacial myologist that we really focus on. So when I assess the airway and nasal passages, I'm not just thinking about resonance. I'm thinking about how the client breathes throughout the day, how they sleep at night, how much effort their system uses just to get air. So, how I assess the airway and nasal passages. First, again, I observe at rest. So I observe their breathing at rest. Before I ask the client to do anything, I simply watch. I'm observing whether the mouth is open or closed at rest, whether breathing appears nasally, orally, or mixed, whether there are signs or effort such as nasal flaring or facial tension. Resting breathing patterns are highly informative for us because nasal breathing at rest is typical and efficient, but mouth breathing at rest often suggests obstruction or chronic congestion. Next, I'm going to visually inspect the nose. So I look at symmetry of the nares. So you can look here, these guys look symmetrical. I'm looking for visible redness or swelling, signs of narrowing, which you can see on this one. This is more narrow than this side. External restrictions often reflect increased internal airway resistance. So you can imagine with this external restriction here, because it's kind of collapsed, he's going to have more difficulty breathing. I then place a small mirror beneath the nostrils and I ask the client to breathe normally. So I'm watching for the presence and symmetry of fogging. Consistently reduced or absent fogging on one side suggests decreased airflow, which may be related to turbinate, hypertrophy, septal deviation, or chronic inflammation. Then I'm going to assess for nasal air escape using pressure-heavy non-nasal sounds. So a common task I'll ask them to do is doing an S or a Z sound, repetitions of P's, B's, T's, D's. Those are all high pressure sounds. And short phrases like pa, 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 sa, 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 big puppy, or take a pack. And I'm going to see if any air is coming out of the nose. I'm going to listen for nasal turbulence and observe for that visible effort or compensatory facial movements. So pressure sounds require oral airflow and velopharyngeal closure. So nasal air escape during these tasks is clinically meaningful to us. And as the client speaks, I'm going to listen for hyponasality. So that sounds like this. Hypernasality, that sounds like this. And cul-de-sac resonance, which is a mix and sort of sounds muffled. And each pattern points toward a different underlying contributor, such as obstruction versus velopharyngeal dysfunction. So someone tell me if you heard hyponasality, would you think it was obstruction or velopharyngeal dysfunction? For hyponasality.
Obstruction.
Obstruction, that's right. Okay. So what are the clinical meanings of these findings? So nasal obstruction doesn't just affect residents, it affects sleep, attention, and overall health. So when nasal airflow is reduced, our clients have to default to mouth breathing, and they develop a low and forward tongue resting posture. They experience increased airway resistance during sleep, and this can then contribute to fatigue, reduced attention, and decreased speech endurance. In children, chronic nasal obstruction can influence their craniofacial development. And we're going to get to how that happens. In adults, it will present as fatigue, headaches, limited vocal stamina, all of that because they can't breathe properly. So we have important clinical distinctions here. One, if we have intermittent congestion, that may suggest allergies. But if we have consistent bilateral or unilateral obstruction, that raises concern for a structural issue. That may be enlarged turbinates, enlarged tonsils, adenoids. Then, if we have nasal emission during pressure sounds, that could point towards possible VPI. And then if we have hyponasality without congestion, so they don't have allergies, they're not sick, but they always sound like this, that could indicate, again, that enlarged tonsils or adenoids. So these distinctions highlight why the observation and listening and context all matter. So again, we want strong documentation. So rather than documenting nasal airflow reduced, I'm going to describe the pattern and the condition. So that may sound like reduced right-sided nasal airflow observed at rest and during pressure consonants, mirror fogging asymmetrically with minimal right-sided condensation. So that clear documentation supports accurate referrals and interdisciplinary communication. So, referrals. Who do you think we would refer to if we had concerns about obstruction or problems breathing?
An ENT?
Yep, ENT. How about if we were concerned about apnea? Do you know who to?
A sleep study?
Sleep study, that's right. Okay, so an allergist, ENT, sleep medicine, all of those if we're noticing airway difficulties. So bottom line for SLPs, airway and nasal passage assessments, it's not optional, it is foundational. So if air can't move efficiently through the nose, then our orofacial system will start compensating. And usually those compensations are not good. We identifying these patterns through our OPE helps us explain stalled progress in speech or feeding and allows us to advocate effectively for appropriate referrals. So an example of that as an orofacial myologist, if someone comes to me with consistent nasal obstruction, they always sound hyponasal. I'm going to send them to an ENT or an allergist before I would start working with them because I will not be successful because they can't be in the proper rest posture, which is their lips closed and breathing nasally, which then I can't get the tone in their tongue proper and then I can't get their articulation. So all of this goes hand in hand and it matters. So these referrals are very important. So now let's look at breathing and oral rest posture. This is another area I begin observing in the lobby and continue to monitor throughout the entire exam because rest posture shows me how the system is organized most of the day, not just during therapy tasks. Oh, sorry, I jumped ahead here. So rest posture reflects what the oral facial system does, what it defaults to when it isn't consciously controlled, which makes it an extremely powerful tool clinically. So how I assess breathing and oral rest posture is before giving any instructions. Again, I just simply watch. I'm observing whether their lips are closed or parted, whether they're breathing through their nose, orally or mixed, whether their jaw is supported or is it hanging open, and whether their breathing looks easy or effortful. And once we cue a client to close your mouth or put your tongue up, we lose that information about their natural resting posture. I also observe it over time, not just once. So I'm looking at it through the entire oral peripheral exam. I watch while the client waits in the lobby during transitions when they're listening to what I'm talking about, because the true rest posture is most visible when their attention is elsewhere. And at rest, the mouth should be closed. We should be breathing nasally. Our tongue should be elevated in what we call a baby suction on the palate. right with our tongue on our spot, which is just behind the upper front teeth. And in this posture, the lips are closed without strain. Our mentalis muscle is relaxed. Our jaw is relaxed but supported. And that tongue provides that gentle palatal contact. And breathing is quiet and efficient. This supports airway health, swallowing, and typical craniofacial development. An atypical rest posture will have open mouth posture, which usually means there's some nasal obstruction, or there's low tone or postural support, or there's a long-standing habit there. Maybe pacifier use, thumb sucking. Clinically, this often correlates with mouth breathing, with dry mouth, increased illness, because when we breathe through our mouth, we are breathing in germs versus when we breathe nasally, our nose will filter out the germs, and it will also lead to non-restorative sleep. So when the tongue rests low and forward, palatal stimulation decreases, our palatal width may narrow over time, and our airway space can be compromised. So the nares actually look smaller when we do not have nasal breathing. A low tongue posture is often both a response to airway restriction or a contributor to ongoing airway issues. And long term, why does this matter? Because if I see open mouth posture or low forward tongue placement, I'm immediately thinking again about that airway and sleep and that long term development. Again, with children, this influences their palatal shape, their dental eruption, their facial growth. And in adolescents and adults, it can relate to snoring, fatigue, and reduced speech endurance. So rest posture is so powerful because it happens 20 plus hours out of the day, which is far more impactful negatively than what we do in a 30-minute session to try and fix it. So therapy can't override inefficient rest posture if structural or airway barriers are present. That carryover depends on the system being able to rest in a functional position. So clinical interpretations, again, context is key. An atypical rest posture alone doesn't equal pathology. I can consider whether the client can achieve typical posture when cued, whether they can maintain it, or whether symptoms like snoring or mouth breathing or fatigue are present. The pattern and the symptom profile guides our next steps. So what strong documentation looks like, again, rather than saying mouth breathing noted, I'm going to document the pattern. Like open mouth posture observed at rest throughout the evaluation, nasal breathing inconsistent without cueing, tongue resting low and forward without palatal contact. This level of detail, again, supports our referrals and treatment planning. So referrals, for this, we are going to look at possibly an ENT for obstruction, or tonsillar concerns and allergists for chronic congestion, sleep medicine if they have possible sleep apnea or snoring, or OT and PT when postural support impacts the rest posture. Okay, we are moving on to jaw here. When I assess the jaw, I am looking for stability, symmetry, and smooth controlled movements because the jaw is foundation for everything the tongue and the lips need to do. So when you look at oral placement therapy, there is a triangle and where they talk about what you work on first, and it is jaw, lips, tongue. Jaw always comes first. So the jaw isn't just another structure to check off. It functions as a mobile stabilizer. And when the jaw is unstable, the rest of the oral facial system compensates. So how I assess jaw function during OPE before asking the client to move, again, I observe at rest. I am noting whether it appears relaxed or tense. Is it supported or is it hanging open? Is there visible asymmetry or a deviation like we saw with that young lady's picture earlier? A jaw that lacks stability at rest will often struggle during speech and feeding. Next, I assess the jaw with simple intentional tasks. So I'm going to ask the client to open and close their jaw slowly, open wide and hold, and move the jaw side to side. And I'm observing movement quality. Is it smooth or is it jerky? I'm seeing if there's any deviations during opening. Are there visible tremors? And does the client report any pain or popping or clicking at the TMJ? So deviation toward one side often reflects weakness or restriction on that side. Next, I'm observing jaw movement during conversational speech, syllable repetition, our diodocokinetic tasks, and reading or counting. A jaw may appear controlled in isolated tasks like opening and closing, but it may lose stability once our functional demands increase. So clinical signs of jaw instability may include excessive jaw movement during speech, sliding forward or laterally to assist articulation, teeth clenching or biting to get the stability that they can't have without that biting, and increased movement as fatigue sets in. These are all compensatory patterns. Again, we're going to look at stability, mobility, and grading in jaw function. So stability, I am assessing whether the jaw can where the jaw can maintain a steady position without unnecessary movements. Because poor stability of the jaw will lead to jaw overuse, will reduce our precision, and then cause inconsistent speech production. For mobility, I'm observing whether the jaw moves through full ranges without pain or restriction. So limited mobility may indicate TMJ dysfunction or what's called TMD, muscle tightness, or structural constraints. And then that grading. Grading reflects control of range and force. So I assess whether the client can produce small versus large openings, if they can move slowly and stop intentionally, or is it like kind of all or nothing movements? Why jaw function matters for speech and feeding, because jaw instability often underlies articulation issues that don't resolve with traditional drill-based therapy. Without jaw stability, that tongue can't refine its movements, and then the lips overwork and speech becomes inconsistent. Feeding may be messy or fatiguing, especially during rapid speech and longer utterances and productions of sibilants and affricates. So we have important clinical distinctions here. One is jaw weakness versus a habit. If jaw control improves significantly without cueing or postural support, the pattern may be habitual or compensatory. If instability persists despite cueing, true weakness or reduced motor control is more likely. Then we have structural versus functional limitations. So if there is pain, clicking, or restricted range of motion, that could suggest a structural issue that warrants a referral. Movement patterns without pain are more likely functional and therapy responsive. And then we have fatigue effects. A jaw that appears stable initially but deteriorates during prolonged speech or feeding suggests reduced endurance or inefficient motor control, which directly impacts communication. So again, we're going to look at strong documentation. Rather than saying jaw instability noted, you want to describe the pattern and the context. So jaw deviation to the right, observed during opening and conversational speech. Client reports intermittent right side TMJ clicking without pain. This level of detail will support appropriate referrals and treatment planning. So for referrals, who do you think we're referring to for jaw issues?
Orthodontist.
Mm-hmm. Who else do you think we could refer to?
Would you also refer to an ENT?
Yep, absolutely, for the TMJ, ortho for TMJ, maybe a PT for jaw and postural support, because it could be something about their posture, their neck, all of that could be affecting jaw. And then maybe a medical professional for pain or neurological concerns. So
I
those are,
was,
yes, please.
oh, sorry, I was wondering, is there a certain age in which jaw um hypermobility, I guess you could say, is typical? Like if the kid is under 5 and when they talk, their mouth move, the bottom jaw moves a lot, or is that atypical?
I think that is atypical. I don't know the exact answer, but I'm going to assume that jaw stability and the grading. I can understand with grading as we mature our grading, our ability to move with more control is going to improve, but we should not be seeing excessive movements or jaw sliding, even at a 5-year-old. But that's a really good question. Okay, we're soldiering on here. Now we're on cheeks. So when I assess the cheeks, I'm looking for tone, symmetry, and function because the buccal mechanism plays a major role in both feeding and speech, but it's often overlooked. So the cheeks help generate and maintain oral pressure. And when the system isn't efficient, other structures again compensate. So how do I assess for cheek function during our OPEs? Again, I start observing at rest. So I'm noting fullness versus flattening, left-right symmetry. I'm looking at signs of low tone, such as sunken or drooping appearance, which you can kind of see with this lady here and this baby. Resting tone gives me a baseline information before movement is added. So next, I'm asking the client to activate the cheeks. So those tasks may include puffing out the cheeks, holding air in one cheek at a time, or maybe holding the air and I'm pushing gently on the external portion of the cheek to see if they're able to still maintain that pressure. I'm observing whether the air can be maintained without leakage, whether one side collapse, whether activation looks smooth or effortful. If they're having difficulty maintaining air pressure, that often reflects reduced buccal tone or coordination. Next, I'm observing the cheek behavior during conversational speech, repetitions of pressure sounds, and feeding if appropriate. So I'm watching for cheek collapse during speech. I'm watching for excessive jaw or lip compensation and food pocketing during feeding. Because weak buccal tone affects bolus, which is the ball of food, that bolus control and oral pressure. So clinically, this may present as a lot of food residue in the lateral sulci, inefficient chewing and clearing, distorted pressure consonants, and reduced speech clarity, especially with fatigue. I'm also looking closely at the buccal frenula, particularly when feeding or speech concerns don't fully align with other findings. So that's inside, and that is like a lip tie or a tongue tie, but it's with the cheeks. So I observe frenulum location, thickness, whether cheek movements appear restricted, and whether tissue tension increases with activation. So our important clinical distinctions here. You have to consider whether reduced performance reflects weakness or coordination by observing response to cueing, whether asymmetry is consistent from side to side, and whether the jaws and the lips are overworking to compensate. Again, we want strong documentation rather than saying cheek weakness noted. You're going to describe the pattern and the context. So, for example, reduced right buccal tone observed at rest and during cheek inflation. Difficulty maintaining air in right cheek without leakage. So again, this level of detail helps you with accurate referrals and treatment planning. So referral considerations, it could be ENT or dentistry for suspected tethered oral tissues, which is that buccal frenum, OT for tone and sensory motor integration, or a feeding specialist when that bolus control concerns are significant. Now we're going to move on to lips. So I assess the lips at rest, in motion, and under functional conditions because lip function directly affects speech, affects clarity of speech, swallowing efficiency, and airway management. So, as always, I'm going to begin by observing the lips at rest. So, I'm looking for the proper resting posture. Are the lips gently closed, or are they slightly parted, or are they open? I'm looking at symmetry, overall tone, and the ability to maintain a light seal without a lot of effort. I also observe the upper and lower labial frenula. So that would be if you pull the lip up and it's above the center teeth here, you pull down and you'll see it down there as well. And I'm noting thickness, attachment, and visible tension. That resting posture reflects baseline tone. It reflects airway patterns and readiness for speech and swallowing. So that open lip at rest might show us that they have low tone, that they're mouth breathing, that they have anterior tongue posture. Flaccid lips or edematous, kind of swollen lips, will often contribute to drooling and reduced pressure. And hypertonic or retracted lips may limit movement and drive compensatory articulatory patterns. So if we have restricted frenula, that can interfere with bilabial closure. It can affect labiodental sounds and anterior bolus containment. I'm also going to assess mobility and control. So again, the pucker, the smile, the alternating between those movements, rounding for an ooh, spreading for an e. I'm watching rapid or alternating lip movements. I'm observing symmetry, range of motion, speed, fluidity, grading, and I'm watching for signs that the frenula is restricting movement, like blanching or visible pulling or discomfort. Lip mobility is essential for accurate bilabial sounds, for pressure generating sounds, and for swallowing, and for airflow control during speech. So that poor grading of the lips, where they can't control the movement, will cause imprecise consonants or difficulty managing liquids. And asymmetry may suggest unilateral weakness or some sort of neuromotor involvement. And then I'm also going to observe the lips during functional speech tasks. So I'm just going to watch as they're speaking. I'm also going to look at it during feeding if needed. So I'm observing straw sipping, cup drinking, spoon feeding, controlled biting when appropriate. And I'm watching whether the lips maintain a seal under dynamic conditions, whether there's anterior spillage, if they're drooling. I'm looking how well the lip movements coordinates with the jaw and the tongue, and whether the lips are compensating for weakness elsewhere. And then I'm also looking here, if you look where it says incompetent lip, I'm looking at the mentalis muscle. This is a hyperactive mentalis muscle, which is your chin muscle. And that is hyperactive because it is helping by pushing up the lower lip instead of this person being able to use their orbicularis oris muscle, which surrounds their lips to help the lips close. So that's another thing you should be looking for. So hypotonic lips, so those relaxed lips at rest with poor closure, will suggest low tone, which will then impact speech and swallowing. Hypertonic lips may suggest tension, which is restricting articulation and feeding. And that asymmetry across the tasks, again, will be concerned for some sort of neuromotor involvement. So rather than just listing our deficits, I want you to document the patterns and the impact. So an example would be lips slightly parted at rest with low tone, upper labial frenum high, attaching with mild restriction on lip elevation. That would give us more information. So referrals, we may look for OT if there's just overall low tone or motor planning. PT when posture contributes to this, ENT or a dental specialist for the functionality of the restrictive frenulum, and then a feeding specialist if the oral intake is impacted. And then we're moving on to tongue. moving on here. So I assess the tongue for structure, tone, mobility, and functional coordination because the tongue, posture, and movement influence our speech, our feeding, our resonance, and our airway function. So we're going to look at our tongue at rest and during movement and functional tasks, and that's going to help us gain insight into neuromotor control, compensatory strategies, and functional impact. So at rest, we're looking at the size of the tongue, the overall texture, the presence of scalloping on the lateral borders here, and also the resting posture. Where is that tip of the tongue? Is it up on the alveolar ridge or is it low and forward in the oral cavity? So again, we talked about resting posture and how that affects airway space, so I won't go into that again. Next, I'm going to assess tongue mobility and precision. So you're going to have the client move the tongue up to the alveolar ridge and down. Can they lateralize to both sides? Can they get their tongue back to their back molars? Can they retract their tongue? Can they cup their tongue and suction it onto the roof of the mouth? And then can they perform rapid alternating movements? So you're looking for symmetry, range of motion, speed and fluidity, grading, force, and the ability to dissociate the tongue from the jaw. In speech, you're going to have them again watch them during conversation. And again, you're looking for that mobility, that fluidity, that grading. And are they maintaining functional positioning? We can do that during feeding as well. Functional positioning during bolus formation and propulsion backwards. Is there anterior spillage? Is there pocketing occurring? Is there good coordination? Or are there compensatory strategies occurring? So if we have tongue dysfunction, we are going to have speech errors, inefficient mastication or chewing, poor bolus control, and airway compromise. I'm going to kind of go through this quickly because we have more to go. I just want you to know that tongue resting with the scalloping on it, which is kind of it looks like scallops on the side, which is up here. That can be caused from a narrow palate, and their tongue is pushing out against the teeth, and that's forming those indentations, or from jaw clenching, that can also occur. The other thing we will look at is tongue tie. And we're going to go into that on our next slide here. So we have tongue tie grading. So if you suspect a tongue tie, you can use something called the tongue range of motion ratio measure. TRMR. That was designed by Dr. Zaghi out of the Breathe Institute. He's a wonderful doctor and we consult with him. And we just love working with the Breathe Institute. So the tongue range of motion ratio is just a functional measure used to assess tongue mobility and identify possible tongue restriction or ankyloglossia. So rather than just focusing on how the frenum looks, this TRMR evaluates how well the tongue moves, which is more clinically meaningful. So what you're going to do, if you have concerns about tongue tie, you're going to have their tongue down in their mouth. You're going to have them open their mouth as wide as possible and measure the interincisal opening. So that is between the top and bottom teeth. Then you're going to have them put their tongue up on the spot and you're going to measure that same opening. And we're going to then divide the difference. So you measure the intercisal distance again while the tongue is elevated, and you divide that second measurement with the tongue being up by the first measurement and multiply it by 100, and then you will obtain a percentage. So if that measurement is greater than 80%, then you have typical tongue mobility. If it is 50 to 80%, you have a mild restriction. And if it's less than 50%, it's a moderate to a severe restriction. So here you can see it's very clear they have a tongue tie. And typically if we send someone to a doctor with that or a dentist, they'll say, oh yes, I can see an anterior tongue tie. What they often don't notice is posterior tongue ties, which you would see kind of back here, because a person with a posterior tongue tie can stick their tongue out, but they can't elevate it. So usually they'll say, oh, they're fine, they can stick their tongue out. But what they're not getting is if they can't elevate their tongue can't go into the palate, it cannot spread the palate, then we're going to end up with a narrow and vaulted palate. and an improper resting posture. Okay, we're going to jump to dentition here. So when we're looking at dentition, we focus on structure and alignment, but we always have to connect that to function. So the teeth influence tongue placement, airflow, chewing, and oral motor strategies. So at rest, we're going to look at rest, speech, feeding. We're going to observe the client smiling, speaking, and gently biting. We are looking for if they have a normal bite, an overbite, an underbite, and a crossbite. And I'm going to go over that in a moment. We're going to look at missing teeth. We are going to see if they have any dental appliances like braces, retainers, dentures, and then kind of the general overall health and hygiene of their teeth. So let's jump to occlusion here. So this is good for you to know so you can document. Here we have normal occlusion. Here's a clear, simple way to determine if it's a class 1, class 2, or class 3 malocclusion without overcomplicating it. First, we have to identify the reference point. So we're going to look at the relationship between the upper and lower first molar. So we have central incisor, lateral incisor, canine, first premolar, second premolar, and here with this line is our first molar. So the cusp of the upper first molar should fit into the groove of the lower first molar. And you can see that here, that is right into the groove. And that is a normal bite. So that's a normal class 1 occlusion. If we go to a class 2 occlusion, which we often call an overbite or retrognathic jaw, the upper first molar sits forward relative to that lower first molar. So the lower jaw appears retruded and the upper teeth appear protruded. And in layman's terms, people call that an overbite. And a class 3 occlusion, which is here, the upper first molar sits behind that lower first molar. So the lower jaw appears prominent or protruded. Sorry, again, skipped ahead by mistake. And the upper jaw is retruded there. So that is how you determine the class 1, class 2, and class 3 is looking at how the first molars work together, upper and lower. And then we have in occlusion an open bite, an overjet, and an overbite and a crossbite. So when we're describing the teeth, an open bite is when the top and bottom teeth don't come together. You often see that in the front of teeth or laterally when we have a tongue thrust or a habit of thumb sucking or pacifier use. Overjet is really what people call an overbite, or it's when you have bucky beaver teeth. So an overjet is the horizontal distance is too much between the lower and the upper teeth. And an overbite is when the top teeth come too far down over the bottom teeth or the vertical line here. And the crossbite is when part of the upper teeth that can be unilateral, bilateral, or anterior go inside the top teeth. So that is what an open bite, an overjet, an overbite, and a crossbite look like. Okay, I know I'm over time. If you have to leave, I understand, but if you can stick with me, we're almost finished here. We're looking at the hard palate here. Hard palate is more than a roof for the mouth. It guides tongue movement, it shapes our resonance, and it supports oral motor function. So during that OPE, I assess structure, integrity, and functional impact because chronic oral habits, tongue posture, or airway patterns can shape palatal anatomy over time. So first, visually inspect and gently palpate the palate. You're looking for shape and height. Is it narrow? Is it wide? Is it shallow? Is it vaulted? You're looking at the width of the palate relative to the tongue. Is it constricted or is it proportionate? And then we're looking at integrity. Are there clefts, fistulas, lesions? And we're looking at the symmetry of the palate. Does one side look higher or lower? And we're looking at the rugae patterns, and I'll show you on the next slide what rugae are. So narrow or high arched palates can restrict tongue movement. They can increase anterior tongue thrust, and they can reduce oral space. Structural deficits like clefts or fistulas affect bolus control, resonance, and articulation. So the width relative to the tongue affects the resting posture and that functional tongue placement. So next, I'm looking at a functional assessment. I'm observing the palate in function in relation to the tongue and the oral motor tasks. Can the tongue elevate to the alveolar ridge and the palate? Can the tongue suction onto the roof? Can the tongue have bolus manipulation during feeding? And then I'm looking at TD, N, and L, so our lingual alveolar sounds, that sounds that require that palatal contact. So key observations are, can that tongue reach the palate fully? Are the movements restricted by palatal shape? Are there compensatory tongue or jaw movements present? Clinical insights is palatal constriction can drive anterior tongue thrust, compensatory jaw movements, hypernasality, or articulation errors. Functional limitations may be subtle, but affect bolus control and speech precision. So interpreting this hard palate finding, a high narrow palate and a low tongue posture plus anterior tongue thrusting will have functional speech problems or swallowing impact. Palatal asymmetry and compensatory lateral tongue movements may mean possible neuromotor or structural adaptations. So red flags you're looking for are clefts, fistulas, severe constriction affecting function. Again, our documentation, you're going to include shape, high, low, vaulted, width, that narrow, wide, and integrity, clefts, fistulas, lesions, symmetry, and rugae patterns. Okay, so our referrals would be to an orthodontist for chronic narrowing of the palate, which will affect tongue posture, ENT or craniofacial specialist for clefts, for fistulas, for severe structural constriction, and feeding and nutrition specialists, again, if it is so narrow that the palatal shape is limiting the ability for the tongue to have tongue-driven feeding efficiency. So let's quickly look at pictures of the hard palate. This is a torus palatinus. It is just a bony protuberance. We are not worried about that. This is a very narrow and vaulted palate. So again, chicken or egg, is that because we were a consistent thumb sucker or pacifier user and our tongue wasn't able to elevate because something was always there? Or this could be caused by a tongue tie where the tongue is resting low and forward and the tongue is not elevated into the roof of the mouth and spreading the palate. We have defined rugae here. Here's a question for you guys. In an adult, what could defined rugae indicate?
Is it that their tongue doesn't reach the top of their palate, so it hasn't softened the arugula, I guess
Yeah.
you could say?
Yeah, absolutely. So your tongue's not elevated there. If you rub your tongue behind your top teeth, it should feel pretty smooth. Children, you're going to see the defined rugae, but as you get older and if you have proper tongue resting posture, it should be smooth. And here is a picture of a fistula. Okay. Soft palate, that is central to resonance, swallowing, airway protection, and we're looking at mobility and symmetry, which will directly affect speech intelligibility and safe bolus management. So during the OPE, I'm assessing resting position, movement, symmetry, and contact with that posterior pharyngeal wall. And I'm always linking those findings to functional outcomes. So at rest, I'm noting the resting height and position of the velum. I'm looking at symmetry. Is one side drooping or are there side-to-side differences? I'm looking for abnormal tissue, scarring, surgical changes. And why that matters clinically, because that resting soft palate position affects our nasal airflow and our resonance. So a low or asymmetrical resting posture may indicate cranial nerve involvement, muscular weakness, or compensatory postural adaptations. Next, you're going to assess the movement functionally by asking the client to sustain a vowel like ah and alternate nasal and non-nasal syllables if appropriate. So we are looking for symmetry of the elevation. We're looking for full reach to posterior pharyngeal wall. We are looking for a presence of, if there's a gap between the velum and the pharyngeal wall. And clinically, why that's important if the symmetrical elevation is essential because it has then normal resonance and bolus control. If we had reduced or asymmetrical elevation, that can cause hypernasality, nasal air emission, weak pressure for plosives, or compromised swallowing. Inconsistent elevation during connected speech may indicate fatigue, coordination challenges, or compensatory timing patterns. So when I'm interpreting these findings, I'm looking for consistent patterns across tasks. So a reduced elevation, asymmetry and hypernasality, that could be possible VPI or neuromotor impairment. Adequate isolated elevation, so is fine, but inconsistency during functional tasks, maybe we have a coordination issue or fatigue issues. So some red flags is if the soft palate is not elevating on sustained vowels, if we have persistent asymmetry, if we have audible nasal emissions during pressure consonants, if we have suspected cranial nerve injury or post-surgical compromise, all of those are red flags. And again, our documentation, it should include our resting posture and symmetry, elevation, the gap size between velum and posterior pharyngeal wall, and the functional impact on resonance, on speech, on intelligibility, and swallowing. And our referrals would be to ENT or craniofacial specialists, if we have concerns about VPI or post-surgical complications or structural anomalies. Maybe to neuro if we are concerned about asymmetry or absent movement, which suggests cranial nerve involvement, or again to a feeding or nutrition specialist if the soft palate dysfunction affects swallowing safety. So here is a picture, go on to our next thing, of our soft palate and tonsils. This I'm not going to go into, but I just want you to look at this. We should be able to see the uvula and the back of the wall here. If we're looking at a soft palate that is not visible at all, that is some airway obstruction there. And with tonsils, they should look like this, where we are just slightly seeing them within the tonsil pillars. They should not be kissing here. And you can do a grading system. So that again is great to use in your documentation. So you can give them an exact number and then you can go back and look in the future. Well, they used to be a 2, but now they're a 4. So we can see if we're seeing differences. Okay. We have cleft palate. I'm not going to go into cleft palate specifically here because I think that is a whole nother CU on its own. But again, you should always be looking for a cleft palate. What I will go over though is submucous cleft palates because that is often missed because the mucosa is intact. So structural deficits can be subtle, but have significant impact on speech and resonance and swallowing. So during the OPE, I focus on careful visual inspection of the palate, on the uvula and the posterior hard palate, keeping in mind that subtle signs may affect velopharyngeal function and require a referral. So we're going to look for the classic triad here. We're going to look for the uvula. Is it bifid or split like you see here? We're going to look at the soft palate and we're going to look for the midline translucent zone here. The zona pellucida, I apologize if I'm pronouncing that incorrectly. We're going to look at the posterior hard palate. We're going to look for a palpable notch or groove, which we see right there. So why that matters. These features indicate possible VPI, and functional consequences will include hypernasality, nasal emission, and compensatory articulation. Then we have to observe functional impact. So have them sustain a vowel for hypernasality, look at high pressure consonants for nasal emission, observe for compensatory articulation like glottal stops or pharyngeal substitutions. So a submucous cleft palate can cause significant speech deficits despite intact mucosa. So therapy alone can't correct these anatomical deficits. Surgical or structural evaluation is essential. So when interpreting the findings, remember, a bifid uvula alone is not diagnostic, but the presence of two or more markers, so the line here, the bifid uvula, and the posterior notch, increase our suspicion. Functional signs would be consistent hypernasality or nasal emission, and that would support the diagnosis. So when documenting, include the presence or absence of the bifid uvula, of the line, of the posterior hard palate notch, and also of the functional impact, hypernasality, nasal admission, compensatory R-tic. And then for clinical impression and referral recommendations, I want you to be able to explain it in detail. So submucous cleft palate suspected, bifid uvula observed, translucent midline noted, posterior hard palate notch palpable. Speech shows mild hypernasality on vowels. And referral, craniofacial or ENT specialist, feeding nutrition specialist too. Okay, last thing. Our diodo co-kinetic rate. The DDK tasks give insight into motor planning, coordination, and neuromuscular integrity, not just speed. So during the OPI, I'm going to analyze both single syllable and sequential repetition of tasks. We're going to observe accuracy, rhythm, consistency, and coordination in addition to rate. So first we have single syllable tasks, or what they call alternating motion rate, AMR. So the client repeats each syllable quickly and accurately on one breath. So pa, ta, ka, pa, ta, ka. We're looking at bilabial control with the pa, the alveolar control with the ta, and the posterior control with the ka. You're observing speed and functional limits, accuracy and distortion, rhythm and steadiness, and consistency over time. So is there any fatigue? Clinical insights will be if it's slow, irregular, or degrading AMRs, and that could indicate weakness in coordination or neuromuscular inefficiency. Next, we're going to assess sequential motion rate, SMR, and that's when the client repeats pataka rapidly and repeatedly, pataka, pataka, pataka. If a child is doing it, you can ask them to say buttercup, 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 buttercup. It's the same thing. So you're observing smooth transitions between articulators, sequencing accuracy, stress patterns, groping, errors. Our clinical insight here is if there are difficulties with SMRs, but not AMRs, that suggests some motor planning issues or programming deficits, which may be childhood apraxia of speech. If there's equal stress or segmentation, that indicates impaired temporal coordination. So when we're interpreting our DDK findings, we're looking at slow, imprecise AMR and SMR. That could be possible dysarthria or weakness. If we have adequate AMRs but poor SMRs, that's motor planning or sequencing deficits. If we have irregular rhythm or fatigue breakdown, that could be neuromuscular involvement. So our clinical red flags are markedly slow or irregular rate, increasing distortion with speed, and inability to maintain the rhythm. When SMRs are harder than AMRs, that's showing that coordination difficulty. And our functional implication is with speech, that correlates with intelligibility, consonant precision, and efficiency. With feeding, it could reflect oral motor coordination, bolus manipulation, and timing issues. And with resonance, it could impact velopharyngeal closure, that timing in rapid speech. And with motor control, it stresses the system, revealing subtle deficits that won't be seen in slow speech. So again, when documenting, we want it precise. We want the AMR and SMR performance, so rate, accuracy, rhythm. Breakdown patterns, was it fatigue? Was it sequencing errors? Comparison between AMR and SMR. And an example of that would be DDK assessment shows slow, irregular AMR with progressive imprecision. SMRs markedly reduced with segmentation and equal stress. Findings suggest reduced oral motor coordination and sequencing impacting speech intelligibility. So referral considerations may be neurology. This could be new or progressive or asymmetrical deficits. OT or PT for global motor coordination or tone. And then it could just say, we need more motor speech evaluations here. We need to differentiate between dysarthria and apraxia. So putting it all together. Form and function. The oral peripheral exam is not about listing parts. It's about connecting form to function. Every finding we identify falls into two categories. Structure, which is the chicken. That's the anatomy, the alignment, the integrity. And then we have function, which is the egg. Movement, coordination, pressure, timing. The key question here is not what do I see, but how does what I see impact what the client can do? So why structure and function can't be separated? Because a high, narrow palate doesn't matter unless it restricts tongue movement, which then affects resonance or alters swallowing. A malocclusion isn't clinically relevant unless it changes tongue placement or distorts sounds or drives compensatory patterns. Reduced tongue mobility isn't the problem. The functional breakdown in speech and feeding and airway management is the problem. So structure and function influence each other constantly. Sometimes structure drives function, and sometimes function reshapes structure over time. So this is that chicken and egg relationship, and we have to assess both. So how this changes your referrals. When you make a referral, don't just document anatomy. Instead of saying high arched palate or restricted lingual frenum or asymmetrical soft palate movement, we're saying high arched narrow palate limiting tongue palate contact, contributing to distorted and alveolar sounds and reduced bolus control. Or restricted lingual frenum impacting elevation and suction, which then affects speech precision and swallowing efficiency. Or asymmetrical velar elevation resulting in hypernasality and reduced pressure for plosives. That's the difference between an observation and a clinical interpretation. And why this matters interdisciplinarily is other professionals don't need us to name anatomy. They need us to explain its impact. So when we clearly connect structure to movement, our movement to function, or function to real world outcomes, we become respected collaborators, not just reporters of findings. So this clarity strengthens our referral. It improves follow through. It leads to better surgical, orthodontic, and therapeutic decisions. And most importantly, it leads to better outcomes for clients. So if you can explain how structure affects speech, feeding, resonance, or airway, you elevate your role. You strengthen the team and your clients benefit. So that's how that chicken and the egg finally makes sense. So here is all the references of today. And here I'm going to leave this up. That is our Camarillo Claremont Monrovia Clinic. And this is one of our lovely teletherapists. Hey, I know we're over time. Any questions at all for me? I know that was a lot of information.
Do you have a suggestion about what we should do next? Because I feel like now I know how much I don't know.
Well, I think the key is because this is recorded, I'll put it up, watch it again, and start creating your what your OPE looks like, what your checklist looks like. Again, not a checklist, but for you to go through and make sure you're hitting upon all of the things. Organize it, what makes sense to you. There's lots of things online too that you can download as far as the structure of an OPE. But if you feel really comfortable with the tongue, but not with the jaw, delve in deeply to that.
Justine, I've been having a hard time finding a throat scope that's not out of stock. Talk Tools stopped selling them. Any
Oh,
insights?
I don't because I have the Talk Tools one and
Yeah, okay.
nothing on Amazon
Like, kind of like a knockoff is
and
up
it's
there.
not, I mean, it's worth a shot.
Yeah,
If I don't have it, I'm using a tongue depressor and my phone.
I
Um,
know. The phone's
it-
not great.
yes, and it's not. So yeah, I have mini flashlights that I like to use because I can
Yeah,
direct the light better that way. But I'm
thank
sorry,
you.
I have the old Talk Tools one from years
Yeah, hold
ago.
on to
Yes.
it.
Okay. So I'm glad it was helpful. And guys, this has taken me 27 years to feel really comfortable doing this. So if you are a student or you're new to this, it will take time. You will get there, go step by step, learn each section, feel comfortable with that, and you will progress with time. I am always happy to help. You have my email, Justine at Justine Sherman SLP. Feel free to reach out.